All right. Thank you all for coming today. And those of you on the webinar, I will let you know, the people in the room, we are doing a live webinar at the same time and recording. So we need to mute myself on the co-organizer. It's the computer. Well, we know it's working. That's great. All right, so up here I have Kristen Bates from the Office of Behavioral Health and Rob Valek from the consortium, and they're going to kick us off this morning. We will have a question and answer session at the end, so please hold all of your questions, jot them down so you don't forget. We will have 30 minutes at the end for that. All right, go ahead, and if you want to move the slides, just look great.
All right, so are we off echo now? Great. Okay, and I can just go here.
Mm-hmm.
Space. Let's see. No?
There we go.
Oh, there we go. Okay, so here's our agenda for today. So for those of you who don't know me, my name's Kristen Bates. I'm the Director of Strategy, Policy, and Communications with the Office of Behavioral Health. I want to thank all of you for coming. I know a lot of faces in the room, but there are some new people. I wanted to do just kind of a quick poll. How many people are here from a provider organization? All right, great. How many people here are from a local community partner that's not a provider of substance use services? Okay. All right, who else is here from kind of a state, county, or administrative role? Oh, there's a lot there. Okay, great. Who else am I missing? Recovery. We got one. And family and consumers right there. Okay, great. All right, well, welcome you guys. We're here today to talk a little bit about the second round of funding, the State Opioid Response Grant. We've been calling it a little bit of son of STR, or the second round of our state targeted response funding. We're so excited when our federal partners at Substance Use Mental Health Services Administration announced that they are going to be continuing this large influx of funding for states to address the opiate crisis. So what this meeting is really about today is to talk to you about what we see as our kind of outline and structure, what we're keeping from STR, which is almost all of it, what the expansion looks like, and then what the roles for community partners are. What else? Let's see. Do we have the basics here? Okay. So you're going to hear from our prevention team at the Office of Behavioral Health. For those of you who don't know state structures, because it's confusing, the Office of Behavioral Health sits within the Department of Human Services. But we also have some other state partners here. I think Lindsay from the Department of Public Health and Environment. Do we have anybody from HCPF here? Healthcare Policy and Finance is also part of it. So, but Office of Behavioral Health is within the Department of Human Services. We are the single state authority. That's why we get the money. So we're the single state authority on substance use and on mental health. And that means that we are in charge of administering this grant. The administration is, I think Chelsea's going to go through some of the money pieces here, but it's only about, I think, less than 5% of the grant is what we're anticipating. We're trying to get as much of this money out the door and to our community partners as possible. I think that the STR work that we've done, the contracts that are already in place, that's really what we're trying to do again. So I think there's a couple of new innovative things that you're going to hear about from our prevention team, our treatment team, and our recovery team. And then we also have contracts and fiscal Chelsea's going to go through. But again, this is a 2-year funding block. So we're not starting something brand new that's going to take a year to get off the ground. This money is in need. We have people in crisis right now. We have the highest rate from preliminary numbers from CDPHE. It looks like we're going to have the highest rate of overdose death in Colorado yet. This is a problem that we're trying to curb as best that we can, but this money needs to get out the door. It needs to get to the communities, and it needs to get to the people who need treatment and continuing recovery services. We, of course, are going to focus on prevention as well. We previously had an 80% requirement to spend on treatment. for STR, for the first round of funding, that has been lifted. So we have a little bit more flexibility. I think we have a little bit more on the prevention side with this grant that we're going to talk about, but yeah. STR is from, let's see, we received the state targeted response grant funding in May 1st, 2017. So we have just started our second year, and so that money is going to go through, that's $7.8 million a year. These are formula grants from the federal government, and what a formula grant is, it's kind of like a block grant. Like, we have to apply and tell them what we're going to do with the funding, but the amount that they're giving us is based on a formula that they used, looking at how many people had died of overdose, as well as the need for opiate use disorder treatment in the state of Colorado. We also have a special guest. Charlie Smith is here from the state, from the Substance Use Mental Health Services Administration. Say hi, Charlie. So I was gonna say, is there anything else that we use for the formula to determine the need?
No, those were the two primary variables that we used.
Okay, great. And then of course, population. So we got 7.8 million per year for 2 years for STR, and that's gonna be finished in April 30th of 2019. Next round of funding, SOR is double. So that's the big news. That's the great news, right? We're looking at $14.8 million per year for 2 years for the state of Colorado. And that starts September 30th, not October 1st. I'm sure there's a fiscal reason for that. September 30th of this year. So there's going to be a 7-month overlap between our STR funding and our SOR funding. So this is why we want to make sure that before this application is due on August 13th is when we have to have our plan in, sent off to the feds. I'm sure we're going to turn it in by the 11th, right, Chelsea? Okay. So by that time, we need to have our plan set. Chelsea's also going to talk a little bit about what that looks like. To be clear, it is a 10-page application for almost $30 million, right? So what we want to talk about today is kind of like, we want to keep it high level. Like, what are the high level pieces we want to make sure that we include in that? But when it comes to specific community partnerships, when it comes to like, hey, I have this special program and it's a 2-page, here's my 2-page description of what I want to do, that doesn't go in the grant application. That goes with our leads of the grant. So our program director, Mark Condagiani. Say hi. Program manager, Linda Martin. Yeah, hi. So that's where we talk about contracts. That's where we talk about community partnerships. A lot of the really specific and the nitty-gritty pieces of this really are going to go through our office and through our partnership with the community. So that's what we want to, oh, and then we also have Jessica Triplett. Say hi. She's our prevention lead here. Okay, so that's kind of what this meeting is about today. We want to talk about high-level things. We're going to go over, here's what we think. What are we missing? What do we need to keep in mind? So when we talk about some of our more successful programs that we've had, what's worked for you or what hasn't? Like, hey, this is great, but you're really missing a key piece of the population, a key geographic or demographic, or what are we missing from what we've done so far? So this is what we kind of want to hear from you today. We have already done a lot of work on this. Again, it's a grant that's due on the 13th so in about a month. And we already have a lot of baseline information. So we have already done a lot of planning. So we don't want to deviate too far. It's not like, let's take all the money and create a opioid full service center at the university, right? Like, we kind of know where some of it. No, Rob wants that. I take it back. That's what we're doing now. So I think that we have a good idea of kind of where the need is. I'm going to let Rob talk a little bit about some of the goals too, but I just have to thank Rob and Whit and the consortium. They've done such an incredible job here in the state of Colorado. One of the reasons our STR grant has been so successful is because of all the groundwork that they had done before we started. We were not starting from scratch here. There were already people who were meeting. There were already great work groups. There was already a roadmap for us to follow. And they've been a really essential partner, as have a lot of our community partners. But Consortium, from a strategic planning perspective, has been our lead. And so we want to make sure that we're not, that we're listening to the work that's been done. We're listening to the research. We're listening to community voices and those community voices that sit on the consortium. So that's a multi-stakeholder group. Let's see, existing infrastructure for services. We're going to talk a little bit about what STR is and what we have already done today. And then we're going to talk about how SOR might be different or might be the same. And then we're also going to talk about the new the expanding activities, and all of these activity conversations are going to talk about what's the funding structure that goes along with it. I'll tell you right now, your managed service organizations, there are 4 of them in the state of Colorado. A managed service organization is in like an administrative body that helps do the planning and the administration of a lot of the funds for substance use for the state of Colorado. They're a statutorily defined organization. They are going to be your friends. If you do not know your managed service organization partners, find them today. We've got some of them in the room. We've got Daniel from Signal. We've got Ann from Mental Health Partners. Who else? You're the only 2 in the room. And then we have some people on the phone also from West Slope and Aspen Point. We have a lot of managed service organization types. Okay, so we're going to talk about the funding mechanisms. Again, contracting with the state of Colorado takes about 9 months for a new contract, right? So we're going to be working with our community partners that we already contract with to try to get these dollars out the door in a more reasonable and faster way than we could if we had to directly contract with and administer all of these funds ourselves. And then again, question and answers at the end. Chelsea, are you going to monitor the questions on the, and then Chelsea Hall is our grants administrator. Say hi, Chelsea. She's been emailing you. She is the queen of all things SOR Grant related. She is actually preparing the application. She's the one who is tracking all of y'all's information, as well as all the things that we're planning on doing and all of the ideas that we throw at her through email or by phone call at all hours of the day. And so she's also going to be your point of contact if you have questions about how do I get involved in this. And she'll be monitoring the webinar for those of you on the phone. So before Rob talks, you guys have any questions for me? Not yet, probably. All right, thank you.
Thanks, and good morning, everybody, and welcome. Thanks so much. I appreciated Kristen and Chelsea and Mark and everybody asking me to say a few words. I don't know why, because it doesn't really add any. I don't think it adds much value into this conversation, but I appreciate it. I think really the point that I wanted to make was that, as Kristen said, I think the purpose of the consortium is in things like this, is in getting people together, collaborating. How can, whether it's OBH, and they've been doing this for years now, since the very inception of it, they're at the table for the formation of the strategic plan. And I mean, for Mark sitting there, you know, people sitting at those conversations from the very beginning. And how do we build this thing? So I just wanted to mainly welcome you and thank you for it, because I think it's a good example of collaborating, helping us do a better job in Colorado. People notice, and I think we do. I think we really do. We do a better job here than most states do in knowing what's going on across agencies, from providers to payers to patients and families and advocacy organizations, and really getting people to come to the table and do this collaboratively. Legislators are noticing. You know, the most recent presentations I've been making are like to the NCSL for state legislators. Back in DC, they're asking, our Congress people are asking us, can you come back and tell the feds how to cooperate? Because you people know how to cooperate. And I'd say, that's an undoable thing that you're asking me to do. So no. But the point was, hey, I think people are taking notice that really it is working, that I think we're doing a better job. And I applaud OBH for doing this kind of thing, because I think it's the very nature of it, that it makes it more successful, and we're going to do a better job because of it, and more people will be helped. And the last point I wanted to make is that I hope everybody, and it's not your fault, Kristen, and I do it all the time, but I hope we start using we language for the consortium, because it's really not us. I mean, it's like us over here at the consortium. It's all of us. We built this thing. It's Mark, it's Lindsay, it's all of us. It's JK, it's Ann that is the consortium. It's the collaboration, and we all own it. So when we talk about it, I hope we all will say, hey, it's ours. It's not those guys over there. We're just trying to provide staff support so we have infrastructure in place to do things like this. So with that, thank you very much for everybody for showing up, and I'm just as eager as you are to hear what these plans are. It's very exciting.
I have to give them an overview first.
Oh.
I get the exciting part, Jenny. You have to wait. Rob, such a great point. SOR Grant is ours collectively, and we are so excited to apply for this grant, get the grant, and then spread the money amongst you all. So just really appreciate you guys being here. Again, my name's Chelsea Hall. I work at the Office of Behavioral Health. I am the grants development specialist, and I get the best job here. Actually, I think Kristen pretty much stole my thunder. She pretty much said all of this already. But just so you know, it is a formula grant. She explained what that is. The total amount is $14.8 per year. Whit was texting me like, what? $14.8 a year? I thought it was over 2 years. So yeah, that's a lot of money. There will be some overlap, right? So as Kristen mentioned, this grant, if awarded, will start on September 30th. Granted, we still have the STR grant, right? So we have the STR grant going on right now. On September 30th, we get SOR. There will be 7 months where we're using both funds. It's going to be really important for those people who administer the funds to kind of track that for billing purposes, invoicing, and all of that. Keeping data separate, right? The anticipated announcement, we're hoping early September. We're hoping we do not find out that we got the grant on September 30th. Luckily, we do have a lot of contracts in place, as Kristen mentioned, but a little prep time would be helpful. If you can massage or, get us the award any sooner. Okay, all right. And that goes for all discretionary grants, not just this one. Okay. Eligible applicants, we are the SSA for Colorado. The Office of Behavioral Health acts as the single state agency. So we are the only eligible applicant for the SOR grant. There's not a match requirement. And luckily enough for me, it's only a 10-page application. But to get all of this information that you're about to hear in 10 pages is difficult. So some of the required activities, so the things that we have to make sure that we do, and as Mark and Jenny and all of them are presenting their activities, make sure you identify some of these as they're talking. So the first one, tribes. We need to make sure that we assess the needs of our tribes and that we're meeting those needs. We need to bring them into our collaboration, and unfortunately, I'm not sure if anyone in the room is here, but hopefully on the phone, representing our tribes. Evidence-based practices, we have to implement evidence-based practices. Recovery support services is a huge one. We have now incorporated a lot more recovery support services. I'm sure you all are excited to hear. And that looks like peer navigators or coaches, training for those peers, and then also some recovery housing. Prevention, training, and communications. With STR, this was huge. Jenny will talk a little bit about our prevention efforts, trainings for our physicians, our nurses, and then also communications. Have y'all heard of Lift the Label? All right, we're gonna keep that going, and Liz will talk a little bit more about that. Licensing, we need to make sure that all our practitioners obtain the data waiver or the DEA waiver. Pay for treatment. This is huge. This is where a lot of money will go, right? This is what we're trying to do with these funds, is pay for those uninsured or underinsured individuals, get them into treatment, and get them into long-term recovery. Jail-based services, we can't forget about that. We're hooking them up among reentry into the community with some of our MAT and other services. And then also our friends at SAMHSA providing technical assistance for us. So if there is an activity that we struggle with, we can always reach out to SAMHSA and ask them for help. So now on to the best part, our restrictions. What can we absolutely not do with this funding? And these are very important. No more than 5% of the total $14.8 million can go towards administrative or infrastructure development costs. I'm not sure of that number off the top of my head, but
$750,000.
Yeah,
Give or take.
we can do it. We can do it with that. I do know this number because this is important to me. No more than 2% of the total grant award may be used for data collection and reporting. That's 280. Dang it, I thought I knew it. 296 for data collection and reporting. And Stephanie will tell you later on, the data for this grant is different, is a different requirement than the data for STR at the moment. So there will be a lot going into data collection for this grant. Only FDA-approved medications can be funded through the SOR grant. Funds may not be expended through the grant or a subaward for an agency who would deny any eligible client based upon their approved medication. So this is a big one. We have to approve those eligible clients regardless of their medication, approved medication.
So I wanted to just add on to that real quick.
Yeah.
So for somebody who's on methadone, buprenorphine, or naltrexone, this is really to highlight that programs that do abstinence only or require any kind of abstinence and consider MAT not to be part of abstinence, they cannot receive funding for this. The programs that do that cannot receive funding for this.
Thank you, Kristen. I will let you know everything that I'm presenting right now is considered to be part of SAMHSA's funding opportunity announcement. It's an FOA is what it's called, and you can find the whole FOA document. It's like 100 pages. It's in my notebook right here. But if you want to download it off the website, you can. You just go to SAMHSA's website, click on grants, click on funding announcements for fiscal year 18, and you can go and download this whole document. I'm just shortening a bit for you. Okay. So more restrictions, of course. The award funds may not be used to pay for the salary of any individual at a rate in excess of the executive level 2. Does anyone know how much that is? It's a federal term, right? It's about $190,000 a year. So I think us at OBH, we're pretty safe. Yeah? I think we're good. We may not pay for any lease beyond the project period. So are able to pay for a lease, just not after the project period. We may not purchase or use the funds for construction of a building. So the whole building a new hospital or an OBH is kind of out, right? No more construction on that. We are asking for a little bit of clarification around an exciting activity that Mark will present. We may not provide residential or outpatient treatment services when the facility has not been acquired, cited, approved, licensed, right? We want to make sure that all of our facilities are safe and licensed to provide the services that they are providing. And we may not provide detox services or withdrawal management, I'm sorry about that, unless they're in transition to MAT. So I think that's a new one for this grant, right? So we just need to make sure that they are transitioning to that MAT services afterwards and the extended release of naltrexone.
So they have to be transitioning to extended release naltrexone? No, not Suboxone? No, it can be to others.
It can be others.
That was an
It
option.
can be others.
Any MAT is acceptable.
Any of the approved?
Any MAT.
Any MAT is acceptable.
FDA approved. Right. Okay.
Well, glad y'all are paying attention. I just had this up just in case. Just in case. This is a restriction. No sleeping. Okay, last three. We may not make direct payments for those individuals to get them into treatment, right? And stay in treatment. One caveat to this is we are allowed to provide incentives for the data collection and reporting follow-up. So Stephanie will talk a little bit about what GIPRA is, and there is a requirement there that you have to do a 3-month follow-up, a 6-month follow-up, and a discharge assessment. So we will be able to provide incentives for those follow-up assessments. Meals are generally not allowed. I think we kept it under the $3 limit for the donuts and coffee, so we should be good. And then we may not support non-evidence-based treatment approaches. So as it was a required activity, we must always support evidence-based practices. Okay, I think that is all for me. I will tell you, we are getting into the exciting part of the meeting. And Jenny Wood is our prevention director at OBH, and she was coming up. I will let you know that as we go through all of these activities, as Kristen mentioned, there are funding mechanisms. So there are dollars that are going to be on the slides, but they will not add up to the total 14.8 million, just to let y'all know, in case you're adding at your desk. These are the contractual amounts. They are estimates. They are all subject to change. So just keep that in mind.
This is back of the napkin math that we've been doing so far.
Yes.
These are, when we're making estimates around $30 million, it's a lot of, let's see how much we can plan. The work that we want to do with y'all is to make sure that we have those specifics right and that we can do that appropriately and that we have the right amount of money for each thing.
Good morning. I have to say, I am really impressed by anyone that can make it here by 8 a.m. because I felt like I ran a marathon by the time I got here. So I'm just going to go over a little bit about what we did with STR, some lessons learned, because some of you know that we ran into some challenges. We initially started with 2 evidence-based practice models, the CRAFT model, which stands for Community Reinforcement Approach Family Training, and that's out of the University of New Mexico. And that's a little different because that is aimed at working with a significant other of the person that's entering treatment. And when we were writing the application for STR, I called the model developer and said, what do you think if we adapt your model to include prevention procedures to teach that person how to build protective factors, resiliency, and reduce risk factors within the family? And he said, that sounds fantastic, let's do it. So we trained on that model with the prevention component last September and began implementation. We also used the Celebrating Families model, which is a multi-family group, and the goal is to reduce substance abuse and also build the protective factors within the family. And probably about 6 to 9 months ago, conversations happened with ARTS, and we had approached our project officer with SAMHSA and asked if we could add the incredible years because that model was already being used and there was a lack of funding to support that model, and they said yes. So we added incredible years, which is not on here. So some lessons learned was we were targeting the opiate treatment programs, and whoa, am I doing this? Oh no, that's not up there. There's something different here on this screen. So, okay, good to see. So there was some limitations with the models in implementing in that setting. So we figured that for SOR, I don't know how you knew what to do there. So with SOR, we decided that we were going to change directions and expand our reach because of the limitations with the models, not the OTPs, in that setting. So we decided that with CRAFT, we were going to look at implementing within county human services with some low-income housing developments, which is still, the logistics are still in the works, so this could change. We need to make sure everyone's on board. And what else? Oh yes, how could I forget that? We had a meeting about that yesterday. Problem-solving courts. And also another component of that, Mark and Jessica and I met with Judge Ashby, who's a former family and juvenile court judge, and now she is with the Court of Appeals, to talk to her about training other judges, because judges are like police officers where they respond better if it's someone that's in their profession delivering the message, to go around the state and educate judges about the use of MAT, because there is still a great deal of stigma with judges and probation officers not being in support. And she said she would love to do it. She even said she would do it for no cost, but we were like, you need to, make some money because you are retiring. And her Chief Justice Boatwright, maybe Mark remembers what his job was. Chief Justice sounds like it's pretty important. He was all about this and thinks that it's fantastic and they can definitely use more education in this area. So anyway, back to CRAFT. Another component that we're adding this round is I called Bob Myers, the developer, again and said, what about adding a procedure on naloxone? And he said, funny you should mention that. I was thinking of doing it, write it up, and let's go from there. So we are going to teach family members how to recognize signs of an overdose, where to get naloxone, how to administer within the CRAFT model, and hopefully they will leave that curricula with their own naloxone kit. So this is a really exciting piece because it's the first model that I know of, maybe someone else might know of, that's going to integrate prevention, treatment, recovery, and overdose prevention. And we're also inviting peers to be trained in our next round of training, which is, I believe, next week. And that's also when the naloxone procedure is going to be released for the first time. So that's really exciting, at least I think it is. What else are we doing? We're still going to be funding Celebrating Families, but one of the challenges that we ran into is it is very expensive and it is very difficult for implementation because you need a minimum of 3 clinicians because of the multifamily group and the different age ranges. So we will not be funding additional trainings. We're really going to focus on the CRAFT model, and we'll also continue to fund Incredible Years. And I think that I covered it all. Any questions? I forgot one piece. We also have a trainer in the CRAFT model, so we will be able to easily retrain people, or if they miss the July training or the next training after that, it will be very easy. I think Jessica's here somewhere. She's over there. She's our CRAFT trainer as of next week. She has to do a training with a trainer, so then she will be very easily accessible and she can go to people in remote parts of the state. And I believe that is it. Any questions? No? Mark is next, I believe. Thank you.
All right, good morning. I'm Mark Contagiani. I know many of you, some that I haven't. Look forward to getting to know you. Let's talk about some of the other activities we're hoping to cover, and again, comparing it to both STR and SOR. One of the things we really worked with, again, as Rob Balak said, was we had a framework in the state through the consortium. Let's not reinvent the wheel. There's a statewide strategic plan. We don't have to do everything because there's other people doing parts of this. And so coordinating and putting some resources in, and those resources look like Whit Euler. Whit, can you stand up? Are you here or did you leave us? He's out doing strategic planning for us right now. So most people have met Whit. But that was a big piece to make sure that our efforts are coordinated. We're going to continue that activity, continue to work with the consortium so that we aren't off doing our own little thing, that we do it as a group. We did some work with the Colorado Hospital Association, and really it said Alto's in there. They were doing some work already. We helped support a big event that they hold in January to kind of talk about some of those activities and other efforts around opioids that are going on. We're also partnering with them to help with some hospital induction pilots, working in the emergency departments to start people on buprenorphine, people that come in for whatever reason, but certainly potentially for an overdose. Why just send them out the door with a piece of paper when you have the ability to actually get them on the path to recovery? So that's an exciting thing. We want to continue some work in that area. Narcan obviously is a huge part. We will continue to support Narcan. Again, it is available by standing orders in Colorado. You do not need a prescription to get it at over 400 pharmacies. You can go in and get it. It is covered under Medicaid, so there's no copay for people with Medicaid. So we need to get the word out there that people can get it. But we also know that there's high-risk populations leaving withdrawal management facilities, starting in opioid treatment programs, going to syringe access programs, you name it. We want to make sure the people that are at the greatest risk have access to Narcan. And everybody in this room a year from now who works with people with an opioid use disorder, who has family members or friends who struggle with opiates, you should all be carrying it. And you should all be trained on how to do it. We all need to be doing this, just like you should all have your CPR card. So we want to kind of think in that way. Next piece is we want to get the word out. We with block grant dollars, we also work with the consortium. Jessica Eady, you can raise your hand, say hello. So she goes out to local communities and takes the toolkits that we've developed at the consortium on safe disposal, setting up permanent safe disposal, some of the information about safe storage, all sorts of things. Hey, how to access treatment. Did you know that your MSO is providing support for people who are uninsured? Here are the providers in your community that are available to take referrals. So we're gonna mint her, clone her, and have more of her. 1.5 more of her. That's a little kind of strange thing, but anyway, we want, because there's a lot of Colorado to cover, and that's a lot of miles that she's covering, and we could be a little more regionally focused that way. We also want to work with our local departments of human services and give them some ability to do some local planning to kind of figure out what they need to do for the populations they serve in their communities. Hopefully they'll be partnering with county commissioners and others to really, and we know a lot of communities already have heroin strategy work groups or those sorts of things, or opioid strategy work groups going on. We want to infuse some money at the county level to help them kind of just do that level of planning and coordinate their activities. Okay, and I think the other part is collaboration with other agency funding around prescribing practices. So this is the other piece where we know that CDC provides some grant funding to our partners at the Colorado Department of Public Health and Environment to really focus on safer prescribing practices. This is really the front end. We know that most of the people who use heroin start by using prescription opioids. We still have a lot of overdose related to prescription opioids. And so we want to change the healthcare system's practice to be safer. We also hope that part of that practice isn't just saying, oh my gosh, I think you might be doctor shopping. I think I need to fire you as my patient, which unfortunately is too often the response from the medical community. And so we want to also talk to them about perhaps you might treat their disorder. and so include that in the discussion, not only better management of pain, but recognition of addiction and proper treatment of addiction, build that into it. So we want to figure out some ways to partner with the efforts that are already ongoing, and we'll work with Lindsay and her team to kind of figure out the best strategies to move on that. Obviously, in the next 22 days, we have to figure that out. Narcan distribution, mentioned that. We're going to continue that effort. We did a lot, but we're going to do even more. Oh yes, and August 31st is Overdose Prevention Day for those that don't know about it. And so we certainly want to we're already working on plans to partner with Harm Reduction Action Center, with some of our MSOs, and with other partners to, again, get the word out at the highest level that overdose is reversible. Half of overdoses happen with somebody present, and those people could have been saved. Overdose deaths happened with somebody present. So those people could have been saved if people knew how to recognize it, had Narcan on them. So we want to really get the awareness up and use that event, and we'll focus that. So just some stats on how successful we've been with STR. 352 reversals were reported with medication distributed just from this grant funding. We've had 961 people trained to administer naloxone. We're a state of 5.5 million. We'd like to train more. 800 new patients getting office-based SDR trained providers. So we really worked with the university with the It Matters program, which provides training for people to get their waiver, and we provided incentive dollars for physicians to, I know that going away from your clinic is costly, so let's cover your cost so that you actually go and get the waiver training. So those over 300 new doctors, nurse practitioners, and physicians assistants have reported that they themselves, these newly minted professionals so far have treated 800 new patients. We need to get that number way up as well. We have 103 million impressions on the Lift the Label campaign. So everybody, if you haven't done it, add another million by checking it out and sharing it on your social media platforms and get the word out there. I think it's really important. We've had a lot of other states reach into Colorado and say, we want to do something like that. Help us out. That's a great campaign, and I know Liz Owens will talk about it more later. Two emergency departments conducting a pilot for MAT. We have the Rocky Mountain Crisis Partners, which is a statewide crisis line. They have 60 crisis line staff, all trained to better serve people with opioid use disorder and help them find the right type of services and supports. And in jails, we had 51 people that were inducted in county jails prior to release with funding from our STR grant. Yep.
Just a quick question. Who are the two EDs doing the pilot on the induction? And if you can repeat the question.
Yeah. So the question was, who are the two emergency departments that are involved in that pilot study? So one of them is St. Anthony's North, and Centura operates that facility. And then there's the University of Colorado Anschutz campus that is the other. So, yes.
Can I ask which jails that people are getting inducted
Yes.
outside of Denver?
So Pueblo, I know, has done the most, and it's largely been, repeat the question, which jails? So we added some additional money to the existing jail-based behavioral health services programs at 5 county jails. The jails that we know that have done the most have been Pueblo. I think that's the only one that we got the reported date on, right, Chakriti? Yeah. So the money was really to help support good handoffs and or inductions pre-release. So we really want to ramp that up.
The funding is at Douglas County, Pueblo, Boulder, Jefferson, and Denver.
Okay, Denver, Douglas, Jefferson, Boulder, Pueblo. Did I miss one or I go? I think I hit them all. Okay. So we'll be looking to add 3 additional jails. We want to continue that work with those. We'll look at 3 other jails. We're obviously targeting those that have high rates of populations with opioid use disorder, because that's the target population, to try to continue that effort. So we had support for the 2 tribes in Colorado. It took a little while to get things going, but we have contracts in place with both the Ute, Mountain Ute, and the Southern Ute tribe. We're excited about that, and we want to continue funding support with the SOR grant to continue the efforts that have begun with the STR grant. We want to keep that going. Another piece that I jumped over there, you can see we have peer navigators. Took a little while to get them hired, but they've been amazing. The idea was looking at what other states had done to really have peer navigators help connect people in need of treatment to treatment locations. We have treatment services in Colorado. Most of our OTPs can do same day admissions. And yet we have people coming to harm reduction agencies or withdrawal management facilities or getting out of jail that are in need of services, and the people that work at those facilities sometimes don't know how to link them to the right medication-assisted treatment. So we've hired peer navigators in each of our regions. We want to build that up, and we want to have the new peer navigators have a real focus on the criminal justice population. We focused on harm reduction and withdrawal management and emergency departments as the places to get clients with the first grant. And we want to continue that and maybe build that a little bit more, no doubt. But we also have a lot of people coming out of county jails. We know that population is some of the highest risk for overdose. We also know there's a lot of resistance in that population, as well as the criminal justice system in some areas, to medication-assisted treatment. And so we really want to have these peers be there to help make that connection and connect people. Tanya, question?
Will there be an increase of peer navigators, or will those stay the same that are hired now?
Yes and yes. There will be an increase, and we'll continue to support those that are already in place. Okay? We want to at least double the amount of peers that are supported. Okay? All right. We mentioned that we have some rural services. What we've seen in Colorado, and this is the big picture. We could pat ourselves on the back in Colorado that we have done a lot of good things, and we have a lot of smart people in the room that are working really hard on this. But if you look at the gap, the people that we know need treatment, a simple estimate is to assume that 1% of the adult population in Colorado need medication-assisted treatment for their opioid use disorder. That's about 44,000 people. If you look at the people, May is the last month that we have available, that are either enrolled at an opioid treatment program or they're getting some sort of buprenorphine product that month. It's about 11,500. We're a little over 25% of the conservative estimate of the people in need getting treatment. Some of it is healthcare system stigma. Some of it is just basic general population stigma about MAT. Some of it is the substance use system and the behavioral health system maintaining stigma about this. We need to do better, and we can. Vermont is kind of the leader. They created the hub and spoke model. They kind of looked at this concept of what's an estimate of need and how do we get to it. They currently have 1.6% of their adult population receiving buprenorphine or methadone. They think that the real estimate is probably closer to 2% of the adult population. But we're going to just set a goal of, all right, 1% of the adult population needs it. We're not there yet. We're supporting, over, uninsured people through the SDR grants, 400 to 500 people a month so far. We hope that will grow that are being supported with MAT. Medicaid's the biggest payer, obviously, for people that are medically indigent. Most people are eligible in Colorado, but just because it's a covered benefit, just because people are eligible to that service doesn't mean it's available in their community. And that's simply unacceptable. And we also know that there's significant gaps in rural Colorado. In southeastern Colorado is a big area of need. And we have providers that are trying to move out there and open an opioid treatment program in Lamar. We're excited about that opportunity, but we also know that there's parts of the healthcare system that simply don't offer it because they don't believe in MAT. I've had a federally qualified health clinic call me and tell me that. That's unacceptable. We must do better. We're trying to make sure that physicians, nurse practitioners, PAs in those communities are targeted for the training to get their data waiver. But if we can't get the doctors in that community because we know there's a healthcare shortage, we're going to bring the doctors to them through video conferencing. And one of the things we've seen other states do successfully, in Western New York, they've got a great program that they started using mobile health units. And so that's kind of that's the big ticket item that we're looking to do, is we're going to get some mobile health units with a nurse, a peer, and a counselor driving around in a happy RV, park in a different place Monday, Tuesday, Wednesday, Thursday, and Friday in rural Colorado, and meeting patients, doing outreach to patients, and enrolling them on MAT and saying, I'll see you next Monday. They can develop partnerships with pharmacies so they can park in the pharmacy parking lot so they can write the script. The peer can walk them right in, get it. We got to work these partnerships out and we got to do it quickly. We're already looking at quotes for properly outfitted RVs or vans. But this is one strategy where we got to get to rural Colorado. We got to provide them the service they need. Telling them that it's a covered benefit but nobody will offer it is simply unacceptable. Our treatment gap, we're at about 25% of the people in need. Between 11,400 or so people are on either buprenorphine or methadone when we know 44,000 people need it. We have to do better. And so this is one strategy to make sure we can get to rural Colorado where there's particular access issues. And you can see it's a big ticket item. And it's a big ticket item because we're going to have the salaries for those three professionals in 6 different vans, 6 different RVs, but we're also hoping to buy the RVs in year 1 so that our year 2 funding will be less for this. And that practice will be sustainable after the money goes away, because again, Medicaid should be able to pay for the counseling service that happens. It should be able to pay for the peer service. It should be able to pay, obviously, for the physician time and the nurse time to administer, to diagnose, to do all those pieces of work. So we've got basically the year or 2 years of this grant to make this thing work so that we've got something sustainable to reach people in the hard to reach places that are struggling. All right, and I mentioned tribal support, continuing that. I mentioned the training to get doctors approved to get their waiver. We want to continue that work, and the concept of MAT deserts. I kind of talked about that. Where are the places where people simply cannot get access to treatment because there's nobody providing it? That's where we want to do the outreach. We need help finding a doctor that's willing, educate them about it, and then get them on board with offering the training. Obviously, we want to continue to support treatment for uninsured individuals through our MSOs. Residential treatment, again, residential treatment by itself does not help people with an opioid use disorder. Okay? But some people, like every other addiction, there's a certain part of the population based on the ASAM criteria that need a period of stabilization. Now, for opioid use disorder, that stabilization should include MAT. So we want to make sure there's some funding specifically for people with opioid use disorder so that they can initiate their MAT in a safe environment, in a stable recovery treatment environment before they transition back to the community. So we want to continue that support. Obviously, continue our support for the crisis line. That's a big piece as well. All right, the peers, there's a lot of things we want to do more with peers. We have underutilized people with lived experience for far too long, and they present a great opportunity to really help people on the path to recovery. So obviously we've seen the success of our peer navigators connecting people into treatment. So we want to hire more through our MSOs. We want to work with the consortium and with other kind of recovery groups to really do some strategic planning of how we integrate recovery into the continuum of care. We need to tackle questions like, what about this whole recovery residence that's out there that's unregulated? What should the state do? Do we work towards accreditation? Do we pursue state legislative change to regulate these facilities that are out there? The feds are pretty clear that SOR grant funding can be used and should be used to explore these issues. There's a need for people to have safe, sober living environments, but being completely unregulated, it's kind of the wild, wild west. And so we're being challenged by SAMHSA to get a grip on it and figure out what it is and what's good practice, set some standards, and work towards that. So we want to do some work in that area.
Do they want them to be regulated?
SAMHSA's not saying that. They're basically saying states figure it out. Yeah, the question was, does SAMHSA want sober residences or recovery residences to be regulated? And that was not the clear message that I got. The message was states should get a grip on things and figure out what is going on and make some strategic decisions, but they want to make sure that places that people go are safe. And one of the things that we've seen, again, like we've seen with some residential treatment programs, is there's a lot of recovery residences that are not MAT friendly. They will tell people to get off your buprenorphine. That's bordering on malpractice, in my opinion. And the lawsuits, I'm sure, will be coming. That'll be somebody else's job, but that's the thing. Charlie, you want to add to that?
Mark, the only thing I would add is that the federal government does not define regulation. And so it's really, that's an option for the state to identify how best to assure safe, functioning residential environments that are consistent with the goals and direction of treatment.
Can you mention what Charlie just
Can you repeat it, sorry?
Okay. Yeah, so the federal government, Charlie was saying, they don't define regulation. They're just really putting that to the states to figure out how they want to go forward. And
You have that listed under MSO contracts, and that's the role the MSOs can play, is to writing some basic expectations into those contracts.
Yeah.
And then enforce it in those ways.
yeah, so to kind of talk about what we have in there, we do want to actually support expansion of some level of recovery or sober living. So that dollar amount was looking at, we know there are models that are completely peer run, that that are evidence-based and that SAMHSA supports. So we do want to look at that area as a possibility. So we want to look at that. We want to do the strategic planning. We'll work with somebody through a documented quote and make sure that entity works with the consortium's recovery group, with the planning and advisory recovery group that OBH runs for our block grant. The other piece that we want, there's two other pieces. One, we need to do more peer training, provide some scholarship money for those people to get certified as peers. We want that peer training to be MAT friendly. We want to make sure that we have recovery coaches that truly embrace the many paths to recovery philosophy. And then the other piece, you see that those letters IPS, individual placement and support. It is a evidence-based supported employment model. It has been used with all populations. It's used in Colorado through a lot of mental health centers for people with severe mental illnesses. It's worked with the developmental disability population, but it's also shown efficacy in opioid treatment programs, actually. And we know that the employment rates of people in opioid treatment programs is pretty low as well. And so being able to help people have a sustainable recovery also usually includes having a good, stable place to live, stable income. So we're going to work with, pilot with 3 of our opioid treatment programs in Colorado to be selected to implement the IPS model. Okay. And with that, I'm going to hand it off to Liz Owens to talk about communications.
Hi, everyone. As Mark said, my name is Liz Owens. I'm the Associate Director of Communications at the Office of Behavioral Health. And I'm here to talk to you about what we've done so far with the STR grant as far as communications. Kristen mentioned a couple of people have mentioned the Lift the Label campaign, which is our public awareness campaign that strives to remove the damaging labels and stigma that prevent people from accessing treatment. And so you can see a photo here of our Lift the Label memorial wall, which was created as part of the campaign. And it has 4,200 pill bottles on it, each of which represents 10 US deaths in 2016 from opioid overdose. And then a picture of the governor signing the wall. So this was at our launch event on May 14th. So the campaign has been going for about 2 months now. And we have created all the different things for the campaign. We have more than 200 assets for the campaign, and I have my notes here because there are so many that I want to be able to read them to you. So first there's the website, which is liftthelabel.org. On the website, you'll find 8 different videos, and these are videos of Coloradans in recovery, sharing their stories, sharing about how stigma played a role in their inability to access treatment or in their recovery, and sharing about the support they received. We also have 20 licensed photographs, and those are also photographs of the Coloradans featured in the campaign. We have 2 different posters. We have 78 digital ads. So if you're on a website, maybe you're on, I see them all the time, but I think that's because they know that I helped to make all of them. But so you might be on like a news article, you might be reading something. I was reading something in my hometown newspaper in Iowa, like an online article, and I saw a Lift the Label ad. So you might see it on a news site. If you're watching a streaming TV service, you might see an ad for Lift the Label. So we have digital ads, we have video ads, all kinds of ads. We have 2 informational brochures. So we have one on naloxone, and that is available in English and Spanish. And then we have a rack card on medication-assisted treatment. And there are materials on the table outside. So at the sign-in sheet, if you'd like to pick up any materials, otherwise you can request them through the website, through liftthelabel.org. And so we have some, so the Lift the Label has been the biggest piece of what we've done through this STR grant. As Mark mentioned, the campaign has generated 103 million media impressions so far. So that's really exciting. We plan to add to that. And then we also have some plans yet in the STR grant period. So we're going to interview some more individuals. We're going to do some more videos. We're going to do some videos on some friends and family members, since that's one of our target audiences for this campaign, is to reach those friends, family members, peers, people who might be able to help their loved ones access treatment. And so we'll be working on those videos soon. And the Opioid Memorial Wall is traveling around the state. Thank you, WIT, for doing such great work. his life dream has always been to shepherd a 34 by 8 foot opioid memorial wall around the state. And it's the goals achieved. But yeah, so, and we are getting tons. Actually, I just got an email right now during this from somebody being like, hey, I saw the wall. I would love to have it at my community event. So we're constantly getting requests. We are, as those requests are confirmed, we're putting them on the liftthelabel.org website. And so there's a section specifically for the opioid memorial wall. And we really are, the requests are varied in that we have the opportunity to get this lovely wall all around the state. So we're really, really excited about that. Another piece is that we've also been, as you all probably know, the Office of Behavioral Health also operates the Colorado Crisis Services hotline. And so another piece of the campaign has been to refer people to the crisis hotline. So some of our ads, our poster, and then we have a website that's opioidcrisisservices.org. And so all those different pieces are making sure that people know that the crisis hotline and the crisis services overall are a resource for opioid or just for substance use addiction in general. And then we are in the process of creating this education for professionals, which is a piece that we're really excited about as well. And I'm hoping to have that done late this year. And so what that will be a curriculum to educate professionals about medication-assisted treatment. The curriculum will address stigma as well. And it will talk about MAT and how effective it is. And so the audiences for that will have behavioral health professionals, medical professionals, and also criminal justice professionals. And so you'll be hearing more about that in the coming months. Yeah, so the communications budget is a small piece of the total, but a super important piece, we think, for connecting all the different pieces and for highlighting everything Mark just talked about and Jenny talked about. We're also doing through the OBH newsletter, which hopefully you are all on the list or have signed up out there, talking about those different pieces that we do through the SOR grant, and we'll be talking about the SOR grant as well. And so we have started some plans for what we're going to do with the SOR grant, and a lot of it will be, continuation of some of this work that we're doing. So I mentioned all those different ads that we're doing to the Lift the Label website and resources, and also to the crisis hotline. We will be continuing all of that. We're super excited about putting more money behind those ads because that just expands our reach. We can reach more people in Colorado. We can reach more friends and family members. We plan to put more money toward the wall. I don't know if this is music toward your ears or not, Whit. But we do want to continue to make the wall available, and in hopes that it will continue to travel around the state. And we're exploring what materials we could create that would be targeted at pharmacies and at people picking up prescriptions, and that would be something that we would do as a collaborative effort with some of our partners. We're also looking at survey questions. We really want to get at the prevalence of opioid use disorder in Colorado, and also community views and attitudes, which relates very much to our campaign on stigma to Lift the Label. And we're also going to try to bring Lift the Label to more conferences and events, just speaking about the campaign, speaking about stigma, speaking about what we're doing here. And then we'll create some new campaign messages that again target those friends, those family members. Will be using the videos that we're creating that target that audience to get more out about the campaign. And then we're exploring what else we can create. So we've discovered that there's there's an appetite out there for Lift the Label branded items. So we had buttons at our campaign launch event. I think many of you were there. We are, the tote bag order should be arriving sometime soon. So we'll have some Lift the Label totes. And then just kind of looking at what else we can do that would create like small giveaway items to have at events coming up. And then we also plan to add one FTE through this, so a communications staffer that can kind of help with a lot of this coordination. The interest in the wall has been more than we could have imagined, I think, and so helping coordinate some of that and making sure materials are getting out and requests are getting responded to, and helping identify some of the media opportunities and so on. And then we're looking at what we can create, because there's been such an interest in communities, what we can create that will make it easier for communities share Lift the Label. So maybe a toolkit of some sort, but something that makes it really easy. If a community wants to talk about Lift the Label at the event or wants to have Lift the Label materials, making sure that they have everything to support those efforts. So thanks so much for your support of all of this so far. And yeah, sure.
Which of the public-facing elements are in Spanish?
The naloxone. The naloxone tool. Okay, sorry. The question was which of the public-facing elements are in Spanish, and it's the naloxone toolkit. But I think that's a good point to bring up. Yeah, sure. And consider some more resources in Spanish. Great. That's a great suggestion. Thank you. Yeah.
I'm a mental health professional, and some of the targeting that was done in mental health towards suicide is geared directly toward men 45 through 64 who've lost their jobs. And so they created an entire campaign based on the people most affected and the people who most needed to be reached. I want to know what portion of your efforts are directed toward the most critically at-need population.
They are, yes. And so the targeted ads that we do that's why they run on websites that talk about, news articles around opioid use disorder, or all of our Facebook ads, for instance, are running, or not all of them, but many of them are running in high opioid use areas. So we have, yes.
The person I saw yesterday lives on the street and does not have a phone.
Sure. And that's where we have some more on the ground pieces of the campaign. I mean, that's where posters and other things like that would come in, but I think that's a good point to consider and something we could consider more for our next round of funds too. Yeah, the peer navigators. I mean, we have some pieces. That's not so much a piece that I think has been done through the communications campaign, but it is through the STR funds existing. Linda's doing this.
Well, and the Lift the Label also focuses on people who know somebody with an opioid use disorder.
Mm-hmm.
So really focusing on friends and family, because that person, even if they did see the ad, might not be in a place to make a decision like, this ad inspired me, today's the day I get MAT. But when they are, we want to make sure their families and friends are there for them and understand what MAT is, what opioid use disorder is, and our understanding about how challenging it can be to get off of it, and really the brain chemistry involved. So we're removing some of that stigma so that when that person is ready, we're trying to make sure that their friends and family and coworkers are going to be ready to accept them, right?
Thank you.
Thanks. Is this mobile ads too?
Yes.
Mm-hmm. Lots of them.
Mm-hmm. Yes. The question was, is this also mobile ads? And it is, yes. Anything else? Great. Okay. I'm going to introduce Stephanie, and she's going to talk about data.
Hello, everybody. My name is Stephanie Russell. You might have seen my name or heard of me. I'm usually behind a computer. They don't let me out in public very often, so this is my big debut. But I'm very excited to be here today. I think if you guys haven't caught on to the possibilities of this SOR grant, this is extremely exciting time to be part of this team and part of this consortium, and I really appreciate Rob's words of this is our collective work. So some of the differences between the State Targeted Response Grant and the State Opioid Response Grant: State Targeted Response Grant did not require something called the Government Performance and Results Act Survey, or the GPRA, affectionately termed. The SOR grant will require GPRA at this point in time. We were able to, thank you to our MSO partners in the room, achieve a 94% match rate with our data for STR grant, which is like really exciting to the data nerd up here. I'm gonna like geek out for a second, like that's really cool. I cannot impress that enough. So if we can carry that over, we're really hoping to investigate all options and opportunities in front of us to create a data collection method that is the most beneficial and efficacious to all of our partners. So right now, 2% of the SOR grant is dedicated to data and technology. That's about $296,000 a year. At this point in time, we're in the preliminary stages of investigating all of our options for data collection and reporting. So we're not sure whether we're going to go through an OBH-funded mechanism or with an RFP. So I promised Kristen I would keep this short and sweet. That's all I have for you. Do you have any questions for me at this time? I try and keep it to the point. Okay, yes, sir. Yes, sir.
I worked as part of I worked for a grant program some of my training from part of the funding was, oh, we're going to put people in place in the jails to do this. But the requirements for reporting were so complex that in the first year they saw 31 people, in part because of the reporting requirements that were written into the grant were like, oh, here's the gold standard on reporting how people are doing, and it made it a difficult barrier of entry into people for the program because of the requirements. So that's a place where you're specifically valuable in keeping the data lean and not making it a barrier to getting into programs.
Absolutely. And so I'll repeat that information if you don't mind, sir, for our friends on the webinar. That data reporting requirements can be so robust at times that it is inhibiting people from getting the treatment that they need. And that's not our goal at all. I happen to have some expertise in CQI, which is continuous quality improvement, and Lean and Six Sigma. And what we've been able to do for our other opioid treatment grants, like Matt Padoa, for example, is our providers, we've been able to help them align these GIPRA questions with their intake process. You have to use the exact language on the GIPRA questionnaire, just for SAMHSA friends who are in the room. But we have been able to align those processes and make this interview into about a 30-minute process, which is pretty phenomenal when you're aligning things with intake. This does, as Chelsea mentioned at the beginning of the presentation, you have a baseline survey. There's 3 and 6 month follow-ups as well as a discharge. So you're talking 4 different survey points. You can offer some incentives for some of these follow-up surveys. Any other questions? I really appreciate that remark. All right, seeing none, I'm going to pass the mic.
Please repeat everything from the audience for the webinar.
Okay. Mark, are you going to join me?
Would you like to? All right. Okay, so one of the things that we heard with the STR grant was I got a lot of emails that said, where's the opportunity for my local community to get some funding to do some planning, to do some locally specific regional work? And because, you know, of the short time period of the grant and the goal to really use a lot of existing contract mechanisms where possible, we really didn't have a ton of opportunities in our first 2 years to do that. That's something we'd really like to change with SOR. So I want to talk, like, this is an overview of things that we've already talked about so far, but really what we're talking about is how local partners can really access these resources to meet the needs of their community. Mark, you want to introduce our managed service organizations and give another quick shout out to them and who they are and how to find them?
Sure. So we have 7 sub-state planning areas in the state of Colorado, and we have 4 managed service organizations. So as you can guess with the math, there are a few MSOs that have more than one region. So Signal Behavioral Health Network, we have Daniel Darding and Christy Jordan, both from Signal today. And Daniel is their CEO, and Christy has really taken a lead on the STR grant, and I'm assuming we'll continue with the SOR grant, and God bless you for that, Daniel, for making that decision. She's been absolutely amazing to work with, as has Signal. So they cover the Northeast Colorado, Denver metro area, and Southeast Colorado. We've got Aspen Point, and I think we have somebody on the phone or on the webinar from Aspen Point, but if you have questions about Aspen Point, Signal can kind of field those and connect you to the right people. If you have questions today, you can reach out to Daniel or Christy and they'll connect you. We have Mental Health Partners, which covers Boulder County. They've got their own region because they're cool, they're Boulder. We got Ann for a day or 2 more, and Dixie, right? Casford. All right, very good. So they're both here for Mental Health Partners. West Slope CASA covers 2 regions, the whole western slope of Colorado. So southwest and northwest Colorado. And Carmen Iachino is kind of a point of contact out there. But again, our friends at Mental Health Partners, if you've got questions for them, they'll help connect you. So the MSOs all work together very closely on all these issues. And since some couldn't travel for the event today, the others can help you with that. Okay.
And Chelsea Hall, if you guys need to know, like, what's their email address, who am I supposed to talk to again? I've got a question about XYZ. Chelsea, again, is your resource for that. Her email is on the invite as well as on this webinar. So Chelsea Hall's the main person. If you're like, how do I get my hands on dollars again? she'll tell you and basically connect you to the right person. She probably won't, she'll probably just connect you to the person to answer your question. Okay, so there's a number of mini grants that we're gonna try to be doing this year. One of them is to connect this work with our larger Department of Human Services mission. We're gonna have some planning grants for communities. We haven't determined the amounts yet, but a couple $100,000 there to do mini planning grants for 2Gen, which is stands for 2 generations. This is for models that are similar to what Jenny was talking about. So looking at parents and children and how we make lifelong changes in families. So increasing family stability, supporting parents who are in recovery, et cetera. So it really is about supporting the parents with the goal also of recognizing their kids need to support their kids through life. The consortium outreach and training. So Mark talked a little bit about this. This is if you have an opioid or if you don't. Oh, I think it's doing the thing again, Chelsea. On the sorry, the thing is my screen went away. So these pieces are really about if you want to create kind of a mini consortium, if you want to create, or if you already have a community engagement group that you'd like to do to say, what are we doing about the opioid crisis? What are the resources available to us? How do we engage the community in a meaningful way? What resources can the consortium give us and OBH and our other partners? That's really what that's for. And that's, some of these again are dollars and some of them are resources. So that's where we can have someone come out to your community and do kind of like a mini training. We also have the big one, the mobile units. That's going to be a lot of planning is going to be involved in that. We're going to be working closely with our SAMHSA partners on identifying our appropriate telehealth partners, making sure we have the workforce to get this done, and basically making bus routes, right? It's like a transportation exercise. So determining what those routes look like and what that mobile MAT induction could include. Rural nurse and physician and nurse training. It Matters, which is the program where we train offices, physicians, and advanced practice nurses and physicians assistants on prescribing buprenorphine. It is actually designed for rural practices. So we've been seeing a lot of the people who've volunteered for this training and been, we reimburse the providers for their time away from their offices. We've done a lot in urban areas, a lot of residences, which is great. These are people who are just getting started out in their career. They're going to get started on the right foot, change the culture. But we also want to make sure that the rural communities are getting this done. We'd really like to do more of that. So this is for especially, ideally, for communities that don't have substance use treatment in driving distance. Maybe in their town, maybe even in their county. We know that there are, how many counties? Half of the counties in Colorado don't have a single provider. There are 64 counties, yes, in Colorado. And about half of those don't have any kind of substance use treatment facility within them. So for those counties especially, this is a great opportunity. But as far as the outreach goes, really we're waiting for the community to say, like, this is where we want to go. We'll be doing some outreach with some of our partners and hospitals, but we really are hoping that people will say, hey, I'm the one who can do this. I'm the community. I want every doctor in my town to be able to do this. And then recovery support service strategic planning. I got to give a shout out. Who's going to be at the Opioid Interim Study Committee on July 20th? Okay. All of you guys should be aware that this is the kickoff of the legislative. You're going to be there, Mark. You're presenting with me. We're presenting together. Okay, so this is a legislative group. It's a group of 10 legislators. It started last year, and they get 6 pieces of legislation that they get through, that they get to recommend for the legislative session. 5 of their pieces of legislation passed last year. It's great. It's a way to get a better understanding of what it looks like in Colorado, fund studies, fund treatment, fund new processes, PDMP. There's all of our state partners are involved in this. So if you're not going to those, they're open all day at the Capitol, July 20th. I think it's like 9:30 to 4. It'll be in room 273, I think, probably the same. 271, there you go. So one of the things that they passed last year was HB 1003, and that requires the consortium do, again, that study on what should regulation look like for recovery. How do we do this in a way that protects patients, but also is not onerous and costly for the community? So if you're interested in that, let Rob and Whit know, let Chelsea know, let Mark or Linda know, and they'll make sure and connect you in the work that we're doing because we're helping fund that. And I think is there anything else local that I'm missing? We're really trying to make sure that like rural communities where we're not seeing, like we've got some really great infrastructure, we want to see that really reach deep into the mountains, deep into the plains, deep into San Luis Valley. We're still seeing Southeast Colorado with really high rates of overdose death. We want to make sure that all of these dollars are reaching those individuals. So if you feel like you haven't been a part of this, we've got new opportunities and we want to make sure that you can be. So please reach out and let us know, and we'll try to get some dollars, resources, support, or even just talk you through what we can do for the community. Okay. Technical questions? So I think that Mark, if you'll stay up here with me, and Chelsea, if you want to come on up. We've got a handful of questions that have come from do you want me to can you put the chat up there so people can ask questions as well? Yeah, and then I will answer the one about tribes real quick. We did get one question that I wanted to address, and that's related to tribes. Thoughtfully, someone has asked, okay, you've got a 10 times higher tribal population in Denver metro area than you do in the reservations, like down southwest. We actually did not include that in part of our planning, but we absolutely will. That's a really good point. We have a new position at the Office of Behavioral Health called the Behavioral Health Tribal Liaison, which is very exciting, funded through the state. And that position will actually be a really key person in making sure that we are engaging with both the tribal governments in a government-to-government partnership, as well as with the community partners that are serving American Indian populations. So thank you for that recommendation, and we'll make sure that that's incorporated into our tribal planning efforts. What's next?
Okay, Mark, if you wouldn't mind answering this one, please describe the
IPS?
64 counties. I don't think that's the answer to this one, but maybe. Please describe the IT enhancements for jail-based pre-release systems, if you can talk a little bit about that request.
Sure. So actually, this past legislative session, there was some efforts to talk about simply medication consistency for people that are incarcerated, and this is for all behavioral health medication. We realize that there's some challenges with all the different county jails having different healthcare systems and those sorts of things. So we wanted to put some money aside to figure out how can we work on some of the technology challenges that some of those county jails have to help with medication consistency, and specifically making sure that it's got MAT options available to that. So it's a relatively small dollar amount, but that's the background behind where that came from.
Do you want to take one from the room? If anyone has one.
64.
Questions from the room?
So are you guaranteed to get this grant? Or is it a competitive bid? Or is all 50 states getting it?
All 50 states and territories. The question was, are we guaranteed to get it? Obviously, we're dependent on the legislature at the U.S. federal government continuing to support funding. But at this point, it is a formula grant. If we apply and we do all the things that they say we have to do and don't do any of the things they say we can't do, we will be awarded. Charlie?
For 2 years.
And for 2 years. So the money's been appropriated for 2 years. So we've got that level of guarantee. Okay, that's good.
The bank account is open for 8 more years.
Okay.
There's no money in it beyond 2 years.
Oh, good.
So Congress has to act on the additional 8 years. That's how we would act. Does that help? Yes.
Gotcha. I have one question that came in, and then I'll get you up in the back there. Who will be overseeing the mobile units? I think Witt's driving them with the Walt. No, I'm just kidding. No. He's simply a chauffeur service at this point. No, but will they be affiliated with local providers or overseen directly by OBH? We're not getting into the service provision business other than our 2 psychiatric hospitals that we operate. So we will be counting on local partnerships and providers to do that. We intend to move this money through our MSOs so that every region in the state will have access to at least, well, there's 7 and we're looking at 6. So maybe not every region, every part of the state. We got to figure that out. Okay.
Yep, go ahead in the back.
Yeah.
I wanted to ask if there's any, or it would make sense to have any orchestrated effort to sort of provide telehealth internet security for jails and prisons. Because there's, when they do it on their own individually and stuff, it's kind of hard to reach them and it's hard to engage them with that.
I'll repeat. Okay, so the question was using some resources to support telehealth into jails, right? That's the question. So in that line item that we have for the mobile vans, we also built some budget line in there specifically for video conferencing capabilities, because we know there's examples, at least like Centennial Mental Health Center has been very effective at bringing buprenorphine treatment to all 10 counties and without having to have a physician drive to all those locations. That capability and money to buy the equipment could certainly be extended. We didn't target jails, but we could certainly, as we look at, again, through our MSOs, if they got a partner agency like a behavioral health provider that is doing MAT and wants to do it with video conferencing, and they have some jails that want to partner, I don't think we'd have any restriction of making sure that the technology is made available there so that you can do inductions pre-release or at least do the pre-screening and those sorts of things. So I think we're open to that, and we have some money budgeted in that big piece for the mobile to include video conferencing, kind of technology, software, et cetera.
What about the software? The two-way communication devices are problematic in that sense that there's potentially security breaches that are, and just the process itself, they can probably buy their own equipment potentially, but figuring out from the IT side about how to do it safely so that there's a process that everyone can harm throughout.
Okay.
I'll just
Yeah, go
real
ahead.
quick on the, I think outside of state targeted response with, as Mark was mentioning, the medication consistency, we actually have some pilots that we're working on with that right now that are, I don't know when they're going to be kicking off for SB 019, Jagruti, maybe 6 months, 3 months. So I don't think that that's actually part of the funding for this grant. I think that that's part of a larger strategy for the Office of Behavioral Health. Because I think that, but I agree, that's really that challenge of understanding the different types of software, technology, and capacity of each jail. We're trying to find actually a number of different solutions that can be right-sized for, if you already have great technology, if you have zero technology, and really focusing on pharmacy benefit for that. We've got a question from Richard. Oh, hold on. Let's see. Where did we go? I scrolled all the way up. Down?
Yeah, down.
Down. Oh, there it went.
Oh, that was already one. We already answered that one.
Okay, sorry about this. There we go. So Richard asked, what provisions are there to provide services to homeless persons or persons who are generally more transient in nature? So there are a couple of options here. One is we have that high utilizer funding for individuals to get residential treatment while they are getting onto MAT. That really is designed for the homeless population. When we say high utilizer, we're looking at somebody who maybe doesn't meet ASAM, American Society for Addiction Medicine, apologies. They may not meet ASAM criteria to be inpatient, but really what they need is residential stability while they get on their MAT, and then get them some case management, group services, while they are on that movement. I think that especially when you're starting on MAT, getting transportation regularly to a location on a daily basis can be really tough for populations who don't know where they're necessarily going to be staying every night or every day. So that really is designed specifically for the homeless population. We do anticipate that the mobile units will also be a really good opportunity for individuals who are traveling, and not just in the Denver metro area. Yes, this is where we have a high volume, but I know that out in Grand Junction, Montrose, you still have a very high number of traveling folks, and we want to make sure that they have access to what they need as available. So I go down, Chelsea. If we're currently getting funds through STR, how will this affect our application for SOR, if any? And that's from Galen. If any, STR funding was made available to CDPHE for distribution to local public health agencies to provide education for prescribers on safe prescribing. There's one, Oh, this is a different question?
That was CDC money.
That was CDC money. So I do think that there are a number of different state and federal agencies that are working to address this problem. The consortium, the Office of Behavioral Health, Lindsay over at CDPHE, there are a number of state partners that are going to be involved in all of this. So we are making sure that those efforts are connected and supported by one another, and especially that we're not competing for time, dollars, anything like that, so that we're really building on the work of the other people. So if you already received money through STR, we're not making cuts. I mean, I think that the only thing that we do have a couple of projects like the ED pilot that does have a contractual end date, and we'll probably be moving to an alternative option for that through alternatives to opiates and safe prescribing. But apart from that, really, we're going to continue with a lot of the funding models. I will say one thing: if you have received funding for this or requested funding and were unable to spend it, we have done some scaling back. If there are areas where we had people who were spending and needed more and got all their money out the door and got all of their outcomes met, we're gonna expand those options. I'm thinking of It Matters specifically as an area. So we're gonna expand where people have actually been able to be successful. Some of the other areas where we haven't had as large of an uptake, we're gonna take it from 800,000 to 500,000, right? And that's gonna be based on our expectations for spend and outcomes from the STR grant. So the STR grant is heavily, heavily informing the SOR activities and funding amounts. What's next? Okay, in the room, yeah.
Is there any focus on working with Department of Corrections, parole, halfway houses? I mean, jails are amazing, but we've been hearing a lot about overdoses in the halfway houses, and I just didn't hear anything about connecting with those agencies.
Sure. One of the first things is currently any community corrections facility or halfway house in the state that wants to have naloxone on hand for staff and training for their staff can access that through MSOs. We've made that the contracts and the MSOs permissive to give it to a library, a community corrections, to wherever it is most needed. So again, make those partnerships. Similarly, if those patients need to be get access to medication-assisted treatment. If they are eligible for Medicaid, there's Medicaid funding. We can help link you. We can certainly have the peer navigators that we talked about to focus on criminal justice population also connect to community corrections providers. So that, thank you for bringing that up. It is a population that also is in need, and a system that sometimes is also needs an opportunity to be educated about MAT. Yes.
Sorry. Bringing off of her question,
Okay.
sometimes a peer person cannot talk to somebody who has current probation or other kinds of, someone who successfully made that transition can't actually talk to people in jails because they have a criminal history, and probation bars people with criminal and use histories from talking to people who are in jail or on probation. So your most valuable resource at connecting with somebody is barred by a systemic issue from connecting with the people most in need.
I think that's a fair point, certainly historically, but we know there's been some opportunities for changing in that. For example, Department of Corrections is pretty supportive of places like Oxford House, and there's plenty of people in Oxford House that have criminal records. I think the peer movement is helping shift that conversation a great deal. And so when we hit those barriers on a case-by-case basis, let's bring that up and let's see if we can at the higher levels try to navigate that for you.
I just want to say there's some nuance to
Yeah.
that. It's not out of the question across the board ban. There's nuance to who can speak with criminal histories. So thank you.
Yeah. Yes, Whit.
Scroll down to the chat real quick.
Okay.
And there's scroll way to the bottom on that.
Question, answer, chat.
Just, yeah, chat right there. That one.
Okay, what about support for organizations like syringe access programs and related harm reduction organizations who are working with the pre-contemplative and contemplative clients? I see those as very effective in helping people make the decision to start into treatment, and they need funding too. So we have with STR, and we will continue to focus on making sure that we help them with naloxone costs, first and foremost. One of the other things we've built into this, we also know that another prevention strategy is making sure that people actually dispose of needles safely and not in the parks or other places where the rest of us might walk or they themselves might walk and hurt themselves. So simply having disposal kits that can be either mounted in parks or given to individuals, that's another piece and another cost that a lot of syringe access programs bear, for which there isn't a clear funding stream. So that's another example. And as we said, really having our peer navigators work with them. And we'd love to have a great partnership. We know that a lot of harm reduction agencies want to make sure that clients feel welcome and not pressured into treatment. But we also want to make sure that if they're open to it, that it's available. So it's that fine balance of not trying to push anyone away that's making the good healthcare choice for themselves to at least come in and get some services at that syringe access program, but also make sure that if they are thinking about getting services, that it's ready. So we want our peer navigators to be good buddies with all the syringe access programs, to be on first name basis, to have the bat phone ready if someone comes in. We'd love to see some lift the label signage and post and information all over those facilities. And we also want to make sure that everyone that's getting naloxone gets the Opioid Rescue app that teaches someone how to deliver naloxone in an overdose. And in the very near future, we'll have a treatment referral component to MAT services so that everyone going to those facilities, if they have a phone, they can get it, or if they're working with those clients, they get it. Okay. If an agency is trained in craft, will they be funded for facilitation, and will there be funding for celebrating families? So if we offer free training and we expand that to everybody, it doesn't necessarily mean that you can go and start it on your own and just do your own thing. Again, we want to be coordinated. If there's an agency, either at Department of Human Services or a problem-solving court or a housing project or any type of place that has an interest in running a craft group for the targeted population, families that might have someone struggling with an opioid use disorder, please reach out and we'll connect you to your local MSO and we can see if a partnership can develop. But just because we offer the training that you might bring to your own community, it doesn't necessarily mean that we can also start paying you individually. But we can link you to your MSO to see if we can make that work. Okay.
Any questions in the room? We have one more on here.
All right, I have to use my eyes. Is it possible for funds to be made available to support local coalitions who are instrumental in implementing interventions to address the opioid crisis? So great question, and I think we have those two opportunities. One will be targeted through the Department of Human Services around that 2-gen kind of planning activities, and I think the other that we talked about was not only are we funding more Jessica Eades in the form of consortium local outreach workers to go to communities, But we're also it's gonna have a little purse string attached to them, so that if you have communities that are trying to say, hey, we need to develop some strategic planning or doing some work in our community, we also want to have some resources available through the consortium, so that will be the place for local communities to kind of connect and coordinate, so they get some funding to support local efforts. So yes, it looks like some more came in.
Can you remind people what is an MSO?
Remind people what an MSO is. They're your friend because they have the money, okay? Because heck, they also have $15 million of marijuana tax revenue. So they are your friend. Managed Service Organization is what MSO stands for. Okay.
And will Fort Logan be expanding into residential treatment?
Will Fort Logan be expanding into residential treatment? Fort Logan right now, I believe you're just talking about the State Mental Health Institute at Fort Logan. There's no intention of making that, of adding a substance use residential treatment on that campus, if that's what the question is referencing. Okay. Yes.
We discussed trying to get MSOs and A's to partner. Is there any place for that in this project?
We would love to see, and again, the question was, we're looking at opportunities for the MSOs and the RAIs to partner. The RAIs, again, are the regional accountability entities. They are the ones that are managing the Medicaid funding, which puts our little $15 million opioid dollars in the MSOs, marijuana tax revenue dollars, and our block grant dollars to shame. They're the big funder. But there are gaps in what they can do. There's access issues. There's no coverage currently for residential treatment. So those partnerships certainly should be happening around all populations of behavioral health needs, at least with the MSOs related to substance use. While we didn't dedicate some funding, I certainly think things like the mobile vans have to have partnerships, because we want to make sure that they're available to Medicaid populations. And so we darn well better make sure that the practitioners that are operating those are able to bill Medicaid effectively, that are in the network, if you will. And you're going to have the pharmacy partnerships and everything. So we need the payers on board, and that's where the MSO funding, which, some of our funding from whatever source can help pay for the uninsured, but Medicaid has to pay for the insured. So if nothing else, that project will force some collaboration, but I think also the opportunity of the residential treatment for people with opioid use disorder is another place where every RAI in the state needs to be recognizing that when they have a client that meets that ASM criteria for residential treatment, whether it's for opiates or not, instead of simply saying, I'm sorry, that's not a covered benefit, they say, please hold while I call my friend Daniel, and see if we can help you out, because they have funding to support the Medicaid population. Whatever funding stream it might be, we can use. So we didn't put dedicated funding to have powwow groups, but I think we will drive collaboration through this effort. What? We encourage powwows. Yes. Oh, there's another one I got to read?
No.
Okay. Yes.
Hey, Mark. I think this question was partially answered earlier, but just as access is important, so is retention.
Oh.
And I think they're kind of linked. I mean, with improved retention comes a greater access to care. We certainly see a lot of people coming in. And more recent qualitative studies suggest that some of the challenges with retention stem from transportation issues. Can you speak a little bit to how this will support transportation for our patients in need?
Sure. So the question that came up was, just as important as access is, retention in treatment is a big issue, and we absolutely see that. When we looked at some of the buprenorphine data, we saw in a 3-month period about 12,000 unique people got at least one prescription for buprenorphine, but in the last month it was fewer than 6,000. So that tells me one of two things: we have a retention issue, we're not keeping people in a maintenance treatment, or the other part is that we have a lot of physicians that are using it as a withdrawal protocol. So those two issues are both concerning. And we know it's a problem with the OTPs as well, with methadone, where you have to come in every day for your treatment. So the question was, retention's a challenge, transportation seems to be one of the barriers to retention. Again, we hope that the mobile vans will be one aspect for that, but I think we have an opportunity to look at some transportation strategies could be also employed with these funding. So I think we're open to that, especially if, an innovator like Denver Health were able to come up with some solutions to help their population that they're serving, and kind of present those. I think we could probably figure out how we can manage that. Again, the Medicaid population, you're supposed to have transportation coverage, but it does get tricky. There isn't bus routes to every neighborhood. I mean, it's not perfect. So thank you for bringing that up.
Mark, can I make a plug?
Please.
So this is Charlie Avery, Regional Administrator for SAMHSA.
Take the mic.
One thing I want to really congratulate all of you is kind of working with the state and looking very closely at how best to spend a large chunk of money. I think that in our field, this has been one of the largest single investments into substance abuse, particularly opioids, and all of your dedication to that, your coordination, the consortium and so forth, really kind of show that commitment to the citizens of the state. The one thing I really want to emphasize that Mark and OBH have talked about is the issue of workforce. So one of the things that SAMHSA, along with our sister agency, HRSA, have been moving very quickly to support an expansion of is the loan forgiveness program, which is operated by HRSA. That has provided, it's been in operation for 20 plus years. It provides loan forgiveness for a service commitment for medical professions as well as behavioral health professions, and primarily in primary care as well as in mental health care. Historically, substance abuse treatment programs and substance use disorder treatment clinicians have been excluded. That has now changed. So as of today, the OTPs, office-based opioid treatment programs, and outpatient substance use treatment facilities doing opioid treatment work can now apply for a loan forgiveness site through HRSA. And then once that site is approved, can now recruit as well as retain clinicians to include physicians, nurses, pharmacists, mental health clinicians, as well as substance use disorder treatment clinicians who are licensed and master's level to actually work in those sites. That will be effective. The application process for those sites is currently open through HRSA, and the application process for clinicians will be starting in November.
Is this inclusive for peers?
It does not. According to congressional language, is for licensed master's level and above. And for those of you who want more information about the loan forgiveness program, you have Steve Holloway here in the state that runs the Office of Rural Health that manages the state loan forgiveness program, which actually coincides with the federal loan forgiveness program. But if you have more questions about that, I'm more than happy to kind of answer that. Unfortunately, I do have to run. But Moses, you have a question.
I was just going to elaborate. So the state loan forgiveness programs are part of the bills that were passed that we talked about a little bit earlier. One of them was to expand that program specifically for substance use providers. So in the next cycle, there's going to be an additional $2.5 million specifically for those providers, as well as some of that money being eligible for providers that want to go up in their substance use provider categories, attached to the lab.
Right.
So the state is also having some retention.
We can get more information out to all of you so that you're well informed, so you can talk within your communities about this. In addition to what Moses is talking about, is this is beginning to ramp up, and there'll be more refinements to the federal program with monies coming out, particularly for a mobile van in rural frontier communities. There's an opportunity to build in a service commitment with loan forgiveness on top of salary to actually recruit and retain those individuals working in those new model environments for opioid treatment.
Is this different from the state one?
Yes, it is. The federal one is actually serves as a floor or base of the loan forgiveness process upon which state loan forgiveness programs tend to either be the same or expand. Colorado and Steve's work has really done an exceptional job in expanding the state loan forgiveness program. Two different pots of money. Okay. Yes. Yes.
Sure, whatever the state chooses to kind of invest in, and Colorado's made a great investment in the loan forgiveness programs. The federal investment is a national program. There are multiple sites. If you are registered as a site, for most of our community mental health centers are registered as sites for loan forgiveness. That's nationally as well as locally.
Yeah, the state just expanded.
Correct. This is an additional expansion federally. Yep. All right. Thank you, Charlie. And I know we need to wrap things up. I just wanted to kind of, for the people on the webinar, clarify the discussion. So the federal government just increased their loan forgiveness program. It's for really licensed professionals and above, but that was on top of the fact that the state legislature already this year expanded some loan forgiveness opportunities that could help other people in the profession, like certified addiction counselors, to pay for their CAC classes. So that's available now. And if you need information about that, if you have any other questions about what we've talked today, any questions like the one in my hand that I didn't answer yet because I'm getting the hook, you can email us and you will get the answer, we promise you. And thank you so much for your time. I'm going to hand it over to Chelsea to close us out.
All right, so as Daniel reminded me, you all want this lovely PowerPoint, I'm sure, with my awesome clip art images. Yes? Okay, so if for those who signed in, I will email you this presentation. So if you haven't signed in, please do so. Grab a donut on your way out. Also, if you parked in the parking garage, we have refundable coupons for you, so you do not have to pay. These are also by the sign-in sheet. You take, please only take one. We don't want to pay for your parking every time you come to school. Okay, so just one of these. It should cover the full 3 hours, right? If you go over 10, which we will. And basically you take the card that you got on your way in, you put that in first, and then you put these yellow ones in after that. Okay, if you have any questions, email me. Like Kristen said, I'm available 24/7. Thank you for coming. And thank you on the webinar for coming. Again, if you have any questions, please email me.